Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Just a reminder to please leave your questions till the end of the presentation. Please enter them in the chat and please answer a brief survey that'll be sent to you right after Grand Rounds. It will let us know that you were present today. And finally, we have a guest speaker courtesy of the Division of General Internal Medicine. I'd like to ask the Chief, Dr. Suzanne Morin, to introduce our speaker.
Thank you, and thank you everyone for joining in. So today we're very fortunate to have Dr. François Lamontagne, who's a professor at Université de Sherbrooke, who's going to discuss the title here, Research and Healthcare, How We Learn and Improve. So Dr. Lamontagne received his medical degree from Université de Montréal and is now a full professor in the Department of Medicine at Université de Sherbrooke. He's also holds a master's degree in pharmacology from Université de Sherbrooke and a master's degree in health research methodology from McMaster. He currently does critical care at Université de Sherbrooke and is a clinician-scientist and clinical trialist as well, internationally renowned, and has led multiple highly important and clinically relevant clinical trials, which has shaped what he's going to discuss with us today. He's also been involved, and you may remember this during the COVID pandemic, Dr. Lamontagne was the lead, the methods leads for a very important paper that kind of provided guidance from the WHO on the use of corticosteroids during COVID-19 infection. So I think we're really fortunate to have Dr. Lamontagne with us, and welcome.
Merci beaucoup. Thank you, Dr. Morin. Thank you, everyone, for having me. It's a real honor and a pleasure. I don't know about everything that was said about me earlier, but it's certainly fun to be here. And I'm particularly grateful that Dr. Morin and colleagues have given me license to talk about what I wanted to talk about. So often when you're invited to give a presentation, it's about your a published study or a trial. It's about whatever you've done recently that attracted a bit of attention. This time I picked a topic which is increasingly what I feel passionate about, what I think is a direction in which we should be moving, but I call it my field of dreams presentation. I'm not sure how to... because it's about something that's not quite finished, not quite advanced, really. It's really a direction in which I thought we should be moving, and perhaps the baseball analogy is not the right one, since this is April, and since we're in Montreal, we might have said that, we have to be skating towards where the puck is going rather than where the puck is. It might have been more appropriate. But so this is going to be a bit of a hodgepodge, not so much about evidence or studies or any particular study, but how we learn and how the research ecosystem delivers or does not deliver the type of evidence that we need to improve the care of our patients and the safety of the care that we deliver. I should be using this one here. So the objectives, which have been distributed, talk about the various stakeholders that have a role to play when it comes to delivering research to generate evidence. I'm going to be talking, particularly in the first part of the presentation, about the costs, the many different costs of the status quo and what it means to not enhance our capacity to deliver the type of research that I think we believe that we deliver, that we should deliver, and how we as clinicians have a role to play. We have to come to terms with our own cognitive biases, I think, but also I think we have to discuss and accept and acknowledge that the status quo sort of weakens the very sort of foundations or ethical foundations of our contract with the public when it comes to delivering healthcare. Anyway, so we'll touch on each of those things in the next few minutes. Sorry, I'm mishandling the... Okay, so the cornerstone for this presentation, which I tend to give in various settings, and I change it, I kind of adapted, but it's that we are living, like there's a pretty significant disconnect between the narrative, the story we tell ourselves about science and medicine and medical knowledge, what it is and how we acquire it, and what we're actually, the pervasive knowledge gap or scientific uncertainty that affects a lot of what we do. It's not that there's a dearth of data. There's never been as much scientific data. There's never been as much, as many studies getting published, but it's not the type of research evidence that is really well suited to inform the care that we deliver. Now, however way you slice it, and I could have picked from a large number of, similar opinion papers, editorials, or studies from American Heart Association or various other sources. This is one recent study by a Canadian lead author, incidentally. This was an international collaborative. It involved colleagues from the US, from the UK. And they basically randomly selected close to 2,500 meta-analyses from Cochrane. And then they passed those meta-analyses through the filter of grade and determined whether, assuming, each of those meta-analyses examined the evidence base for a given intervention, they examined the type of scientific foundation for each of those interventions. And they found at the end of this that the vast majority of all those interventions relied on evidence that was extremely shaky. So 12% only of those interventions, if you believe those meta-analyses, were anchored in evidence that was actually felt to be quite solid. And actually, a lot of those, convincing evidence base was for interventions that were ineffective. So that left quite, a very, very small number of those interventions that were both found to be mostly beneficial and proven by pretty reliable studies. Now, we know that maybe the figure itself, maybe 95% of our interventions being unproven seems a bit much. It might be a bit strong. But the overall principle, I think, we probably accept as true, because when we round every day and when we teach students and residents, we're invariably, quite often confronted with a situation where we're teaching about what it is that we do, but at the same time, in the same breath, acknowledging that it's not founded on very solid evidence, right? So we experience this when we teach. We experience this when we digest, when we look up, when we consume practice guidelines. Now, I work in critical care, so obviously some of my examples are, from that area. But these are landmark, practice guidelines from last year, I think, from the two most prominent professional societies in critical care. You've got the American Society, you've got the European Society, on the exact same topic, looking at the exact same evidence concurrently and drawing very, very different conclusions. Now, invariably, what those guidelines have in common, as every other meta-analysis or guideline that you might read, is that they end with a remark that more evidence is needed, right? So it's very easy to develop this quite, cynical view that, but it does say that somehow we're generating a lot of research, but it's not the type of research that we would need to inform these recommendations. And then, not surprisingly, when the evidence is shaky, it's subject to interpretation and to, concurrent inconsistencies or differences, from two very prominent professional societies. And you have these, you are privy to similar examples, whatever area you practice in. The other phenomenon, which is very symptomatic of maybe a flawed research ecosystem, is this thing that other people have coined medical reversals. Now, it turns out that that's a thing. It's a specialty. There are people from Harvard who write books about medical reversals, and again, this affects every medical area you might work in. So I try to adapt this presentation, and I was presenting this to an ops and gynae group, and I had found examples from ops and gynae, but this time whenever I can, I fall back on what I know more, and so that's acute care and critical care. And so these are just a few examples, but I could have picked any number of examples of things that we did, things like practices that were really entrenched in usual care, things that it was considered standard. And then a point comes when it's evaluated and there's a complete reversal. Like we go from doing something, considering that it's a component of usual care, to actually not doing it at all. So the first time I heard of medical reversals, as we were talking this morning about ACT and talking about PJ Devereaux, the first RCT course I took was given by PJ at MAC. And he was the one who sort of, opened my eyes to he used to love to talk about hormonal replacement therapy in menopause. And I think he still tells the story of how he had recommended hormonal replacement to his own mother. His mother then developed cancer, obviously might have nothing to do with the hormones that she was taking, but he felt aggrieved or distressed by the fact that he had endorsed a very common practice that was uncertain at the time. And there's reason to believe that it probably was not the best thing for his mother. And then PJ, of course, went on to be the lead investigator of another big trial that was that triggered a big reversal. So I trained, learning to administer high doses of beta blockers to patients, high-risk patients, who are about to undergo a surgery, and that's something that we don't do anymore. And so I put up a slide like this with many examples just to get the point across that all of these studies are obviously things that we want to celebrate, right? Because we go from doing something that's ineffective or harmful to not doing it. But it seems like we miss an opportunity to appreciate the implications for having done some of these things a lot for quite a while and actively causing harm that was avoidable and wasting very, very scarce resources. I think that escapes us. No one's jumping up and down, when something like this gets published in the New England and sort of feels too bad for having done a lot of this for quite a while. And I think that's a missed opportunity, because one reason we're not doing the type of research that we know how to deliver, what is the cost of it. Now, the thing is, forget the obviously the more important aspect, which is that some patients are harmed unnecessarily. You don't need a lot of studies like that to pay for research, right? I don't care how much the trick trial cost, and got people who were around maybe when the trick trial was being conducted in Ottawa. It costs a lot of money to bank blood, right? To collect blood, to test blood, to store blood, to distribute it, and then to administer it. And the trick trial is a landmark Canadian trial that found that it was not better to transfuse very liberally the way we used to transfuse blood. It might actually be better to transfuse less. So when you find something like this, you save money and you save lives, and that it's just that the funds, the economies that are being made they come from a different pocket. But there's a realization that has to be made that there's a lot of benefit to de-adopting care that is, ineffective and potentially harmful. So I'm going to single out one of those examples, which is the use of starches in critical care. And again, the intervention itself isn't very interesting, but I picked that example because it's something that I did quite a bit of as I was training when I was a resident, a senior resident, a critical care fellow. And like PJ, with hormonal replacement therapy in menopause, this is the type of stuff that I actively did quite a bit of. And I'm interested in how it is that when we're in the midst of things, when we're in the heat of it, when we're knee deep in scientific uncertainty, how is it that we are so tolerant of uncertain practices, and how it is that we live comfortably in a world where we're not reassessing what we do, even though we're quite good at observing that, a lot of it is uncertain. So colloids, that refers to a type of IV fluid that is still used in the OR, used to be used a lot more in the ICU. It was approved by the FDA in 1972. And so there were studies, right? It's never because there isn't evidence. When we say there's not enough evidence, we need more research. It's not that there's not evidence, it's that there's not the evidence that we need. The evidence is just a bunch of noise, and the evidence we need is not the type of study that we conduct, and it's not the type of research that we consume. So the number of publications, this is a quick and dirty search on Scopus, but from the point in time, things like, starches, things like pentaspan or Volumen was approved, a lot of studies were conducted, a lot of science was published, and the increase was quite exponential up until the early 2010s, when big trials started to come out suggesting that perhaps these things were not really safe, actually. So meanwhile, I'm a resident, I'm a fellow, I'm a young intensivist. There are all these guidelines being published. Each one of those guys, this is one, again, from the American Society, could have, put on the screen the Surviving Sepsis campaign. These guidelines acknowledge uncertainty, right? So there is this caution that these fluids, we don't really know what they end up doing clinically, but all of that is drowned in a sea of data about the osmotic pressure, about the plasma expansion capacity of colloids. So it's sort of drowned in a sea of information, and invariably each one of those recommendations or practice guidelines ends up recommending that it's fine to administer this or pick a different type of IV fluid. We don't know what the evidence is, so the recommendation is conditional, but you're allowed to use it. Until this is what has people like John Ioannidis from California and other people say that most of the research we produce is useless. As a trialist, it's kind of hard to hear these things, right? Because I feel like I've got a target on my back. But what he means is that not that it's irrelevant or it's useless to do all of that other research, but it's not the type of study or evidence that we need to, make clinical decisions or recommend care to our patients. And so there are implications in terms of health outcomes and cost and wasted resources, but at its root, there are bigger implications, I think, that are ethical and that have to do with the principle of patient autonomy, right? So we hold as true that we're supposed to engage in these discussions with our patients and engage in shared decision making and provide evidence to our patients so that they can make their own informed choices. So I'm back with the colloid example and the starch example. For all those years that I was prescribing and ordering starches and pentaspan, I never once approached a patient in the ICU or the patient's family and explained that we were uncertain about the clinical effects of these drugs. Before giving a bolus in the ICU, you would never do that, right? And yet, if you believe this meta-analysis that came after the trials from the early, this was in 2013 from Canadian colleague Ryan Zarikansky, the number needed to cause one unnecessary death by, resuscitating critically ill patient with pentaspan is 66, right? So I guarantee you that I gave enough pentaspan to kill people, right? This was a time when I was living in the ICU. I prided myself on being a very aggressive resuscitator, right? So I would have given volumes and volumes of this to, literally hundreds of patients. So I probably actively caused unnecessary deaths, and I certainly probably precipitated renal failure that led to renal, and yet I never talked about the sort of uncertainty that was acknowledged in all of those guidelines, right? Because in a way, you can't, right? You can't itemize every little intervention, but at the same time, we weren't being fully transparent about how this important component of usual care was really uncertain. And this brings up an interesting aspect here, which is that how and we were talking about this earlier, there's a big double standard in my view, right? We consent to usual care cannot be fully informed if we don't make sure that uncertainty is acknowledged. Now, this can be an explicit informed consent discussion, or it can be implicit, but as clinicians, I don't think we ensure that the public is aware that a lot of what we do is not, fully proven or founded or based in very solid evidence. And, vice versa, consent to research, we're pretty good at getting actually where we have to get consent prospectively. But consent to research is also not informed if the corollary, if the alternative, which is usual care, isn't described as uncertain, right? So when you measure the incremental risk of research, it's not the risk of research. You have to make sure you talk about the incremental risk relative to usual care, which is also uncertain. So I'm a big fan of everything written by a gentleman called Ian Chalmers, who probably wrote the most compelling articles about this. And he is pretty convincing when he explains that we collectively, and this is a big collective, it's clinicians, physicians, nurses, but the public, we're pretty good at accepting uncertain therapies within usual care and then resisting studying those therapies in the context of research, right? That's the double standard that he gets to. It's called the endowment syndrome. When something is permissible, it's very difficult to consider randomizing to a placebo or, not that thing. It's very difficult to let go of it. And when we say that, it's fine to give Voluven or Pentaspan or all these colloids in usual care, but if you do a trial, you need to get a priori consent. This is essentially saying that patients in studies need more protection than the patients receiving usual care. And he describes it as the everyday medical tinkering of, unproven practices. That is a big double standard, and that creates a huge barrier for research and a learning healthcare system. So it's not just about the cost of studies, but it's about why we are making it so complicated to learn. Now, this would be simpler potentially if patients and their families and the public knew that a lot of the care that we deliver is uncertain, but obviously we don't go there much, right? And that's why I think at its root, the care that like the principle of autonomy and shared decision making is not really integrated in the way we practice and in the way we deliver research. Now, I've given you a fair amount of examples from the past, and maybe some of those were too critical care oriented, and there were certainly stories from the past, and hindsight's always 20/20, right? I'm sure that all the intensivists here never gave Pentaspan, and they always knew it was bad to do that, right? But I decided, and now I'm a bit nervous because I see ID people in the room, but I thought it would be relevant to pick a current example, something that we do today, that is, I think, a compelling example of that double standard. So could have picked anything. My own area of research is resuscitation. I like vasopressors, but I would have lost part of the crowd here, perhaps. And we've just been through a terrible influenza season. And so I figured influenza would be a good topic, right? Now, I know nothing. I'm not a ID person. I'm not a virologist, but I had to work with them, or I had to play the part. And so this is the most recent WHO guidance on the use of therapies for influenza, and I sort of copied the recommendation for oseltamivir in patients who are hospitalized. So the WHO separated the recommendations in non-severe and severe influenza cases as basically anyone who is admitted to the hospital or the ICU. Now, I know this literature because I chaired the previous WHO panel. I was the methods chair for the previous one, and then they asked me to be part of this one, and I declined because basically lost most of my hair doing WHO guidelines with them in the past, and I figured I should move on. And I kind of knew where this was going, and I didn't want to sort of play in that movie again. The recommendation for oseltamivir in patients who are hospitalized with influenza is, not surprisingly, conditional, so weak recommendation in favor, right? And then they acknowledge, if you read the text, that the panel determined that this was the weakest grading you can come up with. It's very, very low evidence. That's the grading that they attributed to this recommendation, because essentially it hinges on data from 100 participants in 2 RCTs. One of those RCTs enrolled kids from 0 to 9 years of age, and the other enrolled adults. and they didn't collect anything about the variants, and so, and it's old data, and they're extremely flawed. Like any kind of bias you can come up with, like those two trials had all those flaws. Essentially, there was better evidence for hydroxychloroquine for COVID in May 2020 than there is for oseltamivir if you consider the clinical trial data. And yet they said, well, it's very flawed. We acknowledge it's flawed, but that flawed evidence doesn't suggest any kind of difference in mortality or important outcomes, but there's just one secondary endpoint that, I guess, and it can't hurt, right? It's like vitamin C, it can't really hurt your patients. So they come up with a conditional recommendation in favor of oseltamivir, acknowledging it's extremely weak. I am very confident, I don't know because I don't work here, but I'm very confident that every patient in your ICU that has influenza is getting oseltamivir. I'm pretty confident that every patient on the ward with influenza gets oseltamivir. Now, and that's so we don't have that equipoise. It's like this cognitive bias. We can sip our coffee and teach our residents that the evidence is flawed, but when push comes to shove, everyone gets Tamiflu. Now, it goes further than that. There are trials now that are randomizing patients with influenza to high-dose oseltamivir, low-dose oseltamivir, and placebo, right? And those trials, which are occurring around the world, maybe you're participating, maybe not, but we can't get sites to participate because they don't have equipoise for placebo. The only interventions clinicians are willing to enroll patients in are high dose versus low dose, but they won't consider not giving the antiviral, right? So that's how you end up perpetuating a state where you have no evidence to inform the care that you give to your patients every day. So I've looked to the past. This is the paradox. I think we've got problems with the research ecosystem right now. I think we generate a ton of research. It's really costly, but rather than solving it, it perpetuates uncertainty. Then I put on my scrubs, I put on my clinician sort of gear, and when I change office, when I enter the ICU, all of a sudden I don't recognize that scientific uncertainty. I teach it, but when I'm in the ICU, I give vasopressors like everyone else. There's no data for that, right? And then at its root, this I think undermines the principle of patient autonomy and informed consent, and patients don't know about it, but if they did, I think it would shake maybe their confidence in our community. And obviously, uncertain care means that not all of it, some of it's going to be beneficial when it's appropriately studied, but some of it is ineffective and just wasteful. Some of it is harmful, right? And we're still doing it. And this is what's mind-boggling, is that this is something we can fix. Like an RCT is not rocket science, right? It's really dirt simple. We know how to do RCTs and studies and knowledge syntheses. It's really not that complicated. So we are making it complicated for ourselves. It's like a collective choice. The proof that we know how to fix this is that we've done it. We've just been through an ordeal where we went from not knowing anything and from recommending. Now, this is the big deal, right? In spring 2020, the US government wrote some high priority legislation giving emergency approval for hydroxychloroquine for COVID. This law that was sort of signed by Congress, in earnest because it was so pressing, to basically allowed them to stockpile hydroxychloroquine for COVID, creating shortages in rheumatology. Like this is all factually correct. And they were actually getting ready to facilitate the mass production of hydroxychloroquine because they were causing so many shortages that they had to produce more. So we went from a state where this was a big deal. And by the way, I know that retrospectively we in Canada feel superior to Brazil or the US because we didn't order as much. You know what? Your pharmacy stockpile hydroxychloroquine enough to fill Olympic swimming pools, just like my pharmacy did. There was this big sort of group of big tertiary hospital pharmacists, and they stockpiled hydroxychloroquine. We may not have administered as much of it, but we were like everyone else and had the uncertainty continued, we would have started prescribing hydroxychloroquine the way, some of us gave vitamin C for sepsis, or I don't know, Mucomyst for, anyway. So now this didn't happen, obviously, because this happened. Now, in a matter of 3 months, right, between March and June 2020, the UK investigators polished a protocol for an RCT. They distributed the protocol to all of the REBs and lawyer offices of all of the 150 to 200 sites in the UK. So all of that contract signing and REB approval stuff, that happened fairly quickly. They trained all those sites to deliver the RCT. They enrolled, they collected the data, they followed up, they analyzed the data, they wrote the article, they published it, they peer-reviewed it, and in June, we had the answer. They had enrolled in a matter of 3 months. They went from not having a study to having a 10,000 patient RCT in 3 months. And they had solved the hydroxychloroquine question and that corticosteroid question that Suzanne mentioned, right? And we wrote the guidelines and then we moved on. So it's possible. It's totally doable. It's a matter of collective choice. Now, my concern is that I think we drew the wrong lessons from the pandemic. People say, oh, it's the adaptive trial design, or it's the Bayesian stuff, or it's Martin Landry and Peter Horby. It's none of those things. It's the country. That country had set up its research ecosystem to enable that type of study. So I'm a friend and colleague of Patrick Lawler from your institution. We're both members of this platform trial called REMAP-CAP, and a year and a half into the pandemic, REMAP-CAP got its first big break, and we beat recovery to, the publication of IL-6 receptor blockers, right? That was our big break. Even in REMAP-CAP was promoted not as a UK trial, but as a big international collaboration. Well, this is the enrollment in REMAP-CAP. So look at on the right side of the screen here. There were like 800 patients or 900 patients in that particular analysis. They were all recruited in the UK. It's not a design issue. It's not a PI personality thing. It's the country had set up a system whereby it's possible to deliver that type of research that we lack so much when it comes to guiding the care that we give our patients, right? So how do we emulate this? And this is where I break in my presentation from talking about the status quo and all the problems and all the flaws in our research ecosystem that are kind of common knowledge to what I think we should do. And there was a point where I was like PJ or Paul Hébert or everyone has a solution, right? Everyone has an idea about how to fix this. And I no longer do that. I still have my views, but I don't talk about how I think we should fix it, because what I've come to realize as we were writing all those guidelines with the WHO and noticing that they were all coming from the same country is that when the rubber hits the ground, delivering a trial like recovery is not something that's done by the PI or the funder or the flagship institution that acts as this. It's not Oxford, right, that delivered recovery. It's those clinicians, doctors, nurses, physiotherapists, whoever, who worked across those 200 hospitals from the UK, health system. Jason and I we both lived in the UK, and we worked with someone who realized this and contributed to setting up shop, enabling this type of research. But research is something that in Canada is discussed when it is discussed amongst researchers. It's McMaster or McGill, and it's CIHR, and it's a few prominent researchers. It's not really a discussion that branches out to everyday clinicians. And yet, when you deliver the study, The reason you're enrolling 300 patients and not 30,000 patients, it's the clinicians, it's the patients who don't consent because we haven't told them that the standard care was unproven. It's the guideline writers who, with very flawed evidence, keep perpetuating those conditional favorable recommendations and who lack the courage for, saying, look, we don't know whether ivermectin works. You can't use it. Use it in the context of a study, period. Right. So there was a moment in time when there was that courage, that acknowledgement, but normally that doesn't happen. So rather than telling you how I think we should do it, the message from this presentation is that I think it's a bigger discussion. And I think all of those different interest holders or stakeholders need to see the same thing, and then the solutions will sort of arise. Now, in the UK, they were able to build this research ecosystem. It was a very top-down decision, right? It started from the top, Susan Davis, and then it sort of trickled down. But not only was it top down, but they have a simpler system to handle. All of these stakeholders in Canada are distributed in a very, very complex organigram. So health research is mostly a federal jurisdiction, but then you've got all the private sort of companies and industry. And then healthcare, however, is mostly the delivery of healthcare is a provincial jurisdiction, but then public health is federal again. And so all of these different stakeholders exist in all of those boxes. And so Canada is complicated. I don't know how we're going to get there, to be honest. What I do think is that the starting point is not coming up with a ready-made solution, because it's actually working on the transparency of it all, making sure that these different stakeholders have access to what's happening currently within the ecosystem, and then people can agree on what the problems are and what the solutions are. So as we were writing those guidelines, sort of pulling our hair, trying to emulate something like recovery in Canada, it occurred to us that no one really knows what happens within the research ecosystem. All of this happens behind closed doors, and no one knows what the other hand is doing. So we built something that we call the Canadian Clinical Research Network. And again, that's a bit of a wink to the UK system, which also has a clinical research network. And we use this infrastructure. Imagine a dashboard that sheds light on what happens in health research in a country, in this case in Canada. And the first time we took this infrastructure for a test drive is in 2023, when we looked back and examined the research that we delivered in Canada during the pandemic. Now, as an aside, CIHR only funds a tiny part of the health research in Canada, but it's the only information that's readily available. Somewhat surprisingly, information about the existence of studies is treated like, like a national security secret, and REBs can't release information about ongoing studies. I'm not talking about the primary health data. I'm talking just about the existence of studies that are all registered anyway on clinicaltrials.gov. But if you want to know what studies have been approved by REBs across this, in this province or across Canada, that information is sort of secret for now. So we used the only information we had, which was research funded by CIHR. And we picked out studies that enrolled patients who were hospitalized with COVID, just to see what our ecosystem delivered. We found 26 studies, and we managed to retrieve information on 23 of those studies, and we separated the RCTs from the observational studies. So without going into the details, just look at the left side of the screen. There were 18 RCTs. We found, we got data on 16. Those 16 RCTs over a period of 3 years, from early 2020 to mid 2023, 16 RCTs enrolled 3,800 participants across 78 hospitals. In 3 months, one trial, 10,000 patients in the UK, right? So it's not the same ballpark, not the same, and I guarantee that almost all of the recommendations for therapies that we delivered to COVID patients who were hospitalized during the pandemic were not answers that we found in the Canadian studies. It was all generated by Recovery and other similar big studies. When you look at what comes out of your research ecosystem, you can actually also look at the sites that participate, the sites that deliver those studies. So on this map, you've got the blue dots, which represent every hospital that did not participate in one of those CIHR-funded studies, and those red circles, the white dots, are those sites that were sort of research active in CIHR studies during the pandemic. So those 78 sites that enrolled in RCTs, they're sort of drowned in the sea of blue dots here. A lot of those blue dots are flagships of academia, right? A lot of those blue dots are prominent, tertiary hospitals, and they saw a lot of COVID during the pandemic, but they didn't enroll in CIHR studies. So few sites participate. And of those 78 sites that did enroll in RCTs, you can actually rank them. So each bar on this histogram is a hospital. And on the y-axis, you've got the number of participants enrolled in RCTs. And so we've used this sort of heat map or this color code to identify the top recruiters on the left. And you can see that the bulk, most of the participants in all of those CIHR-funded RCTs were enrolled in a very small number of sites. Most of their quote-unquote research active sites ended up not enrolling many patients at all. So few sites are research active, and those who are research active aren't really active. So there's something here that perhaps we want to fix. Now, if you monitor this, you get to know about the sites that participate, you get to know about the studies that get funded, whether they're completed, whether they're, published and cited, whether they inform guidelines, whether they inform those WHO guidelines or any other guideline is one measure of impact. But there are other, there are many other measures of impact. But you can only start to fix your research ecosystem if you actually pay attention to it. And this is kind of what we want to do. So I'm not particularly interested in COVID, not by a stretch, but we would like to take this model and expand it. And the reason I seize every opportunity to talk about this is I think that expanding it requires the building of bridges and partnerships and collaborations across many different places, because it's still not relevant if it's very niche or we're very sort of focused on critical care research. It's kind of irrelevant. For this to work, you need to see the big picture, because all of those studies exist in the same health ecosystem. It's very important to know about the studies that compose our health research portfolio, but in parallel, you need to learn about the sites that deliver that research. And it all gets crunched in the same database. And this is an iterative process. You need an inflow of information, but that information needs to flow back to all of those stakeholders who don't spend a lot of time thinking about research, but who actually need it. On the back of an infrastructure like this one, you get to test things. And so we've started to do this. We decided that we would sort of mimic a pandemic or a health crisis, and that we would ask of every site that has an ICU in Canada what was asked of sites during the pandemic, which is, tell us who's in your ICU, and remember Sprint, SARI, and all those studies that were trying to characterize COVID. So this is a point prevalence study is the simplest study design you can think of. You don't follow patients, you don't administer an intervention, you don't collect blood. You're taking a snapshot at one point in time. And we invited every hospital with an ICU to participate. And so there were about 300 sites. We got 158 replies. After about 3,000 emails, way too many telephone conversations, 98 of those 300 sites said, sure, we can, collect information on one day, to tell you what patients are lying in our ICU beds. But on the specific date, it turns out that only about 40 sites were able to sign the contract, get the protocol approved by REB to collect data, just describing patients lying in an ICU bed, no consent, no follow-up, no nothing. We use the ACT template, the data sharing agreement, whatever, that template, because it wasn't really for a point prevalence study that was designed, but it's kind of relevant. It's observational data. It's about sharing information. You would not believe the grief that we got from lawyers at prominent academic institutions who were signatories to the ACT template. Like, these prominent universities said, yeah, we buy into this ACT vision, we're all for it. But your study is not exactly the study for which this template was intended. So we back and forth, we said, all right, then we'll send you another sort of agreement template. That one wasn't good enough, and it wasn't translated in French. So we had to, these people deal with contracts that are written in English all the time. So we are creating these barriers, and in 3 months, they enrolled 10,000 patients in RCTs, and in 3 months, we managed to activate just a handful of sites to deliver a point prevalence study. So we're going to keep doing this and keep monitoring this type of the type of research that we deliver in a research ecosystem. Sorry if the layout is a bit messed up here, because the reason we want to do this is that I think that the pillars of a learning healthcare system require 4 ingredients. So rather than coming up with a solution and saying, well, we need to fund more trials and it all needs to go to critical care, I think what we need is transparency. If you want your research health system to deliver what we need, you need good information and data on the disease burden. We need to understand the problems that plague us. We need to understand how patients are treated. We need to understand what usual care is. It is highly variable. And so that already exists. That's epidemiology, right? That evidence it needs to be pulled together, but it exists. You need to have a good understanding of the scientific certainty of those components of usual care. And we already have that. Those are knowledge syntheses and meta-analyses. What we don't have is a decent idea. We don't have good information on the content of the health research ecosystem. We don't know the studies that are ongoing, what they study and what they do. Now, from the beginning of this, I'm going to stop here. I'm at the end of the presentation, but you might have guessed that, I like trials, I do trials, I like critical care. And from the examples that I've selected, you might be thinking that what I want is more RCT funding for my own studies. And you would not be wrong, but that's kind of beside the point. The reason we're doing this is that everyone has their vested interest in this. Whenever you bring up, health research and you talk about clinical research, then you've got, half of the room who really loves basic science jumping up and saying, you're getting all the money for your trials and, we need it for... The thing is, you need to see all of it on this dashboard. And I think legitimately we being the clinicians, the health system, the Canadian public, we should want to have access to the information because all of that research occurs in our collectively owned healthcare system. So the real cost of a study is not the grant that you get from CIHR. It's not what the company pays. That, by virtue of being conducted in a hospital, someone paid for the cement, someone paid for the workforce. But if it's happening in our publicly owned health system, we have a stake in this. We legitimately should expect to know the type of research that is using this collectively owned infrastructure for the same reason that we have the right to know who the government is distributing our electricity to, right? And if you look at all of the pieces, all of those different studies, the phase 1 studies, the first in human studies, the phase 2, phase 3 studies, the basic science, all of those studies exist in the same ecosystem, and only once you see the full picture can there be a discussion amongst all of the relevant stakeholders. But it's also the condition that you need to fulfill in order to see solutions. And this is something that we wrote, Paul Hebert and I, before he was sort of chosen as CIHR president, but there are really, really low-hanging fruits here. Currently, we don't know. The CIHR doesn't know what it's funding. The right hand doesn't really know what the left hand is doing. And we are in parallel funding biobanks and clinical trials that recruit the same patients, collect the same blood and the same data. Meanwhile, all of this work, the consenting, the tapping of veins and the collecting of data, that can all be sort of integrated and biobank infrastructure can be nested within trials. So started out, talking about how we improve, moved away from, telling you how we should do it. But if there's one thing I'm pretty confident about, it's that it's all going to be about transparency. I think we should move away from entrusting the business of research to research institutes, researchers, and have this discussion once all of the information is available to all of these stakeholders with a much broader citizenry. So thanks. That's pretty much it for it.
Thank you very much, François. C'était excellent. So we'll start with questions. Maybe, I don't know if there's any, we could start with the room. So with Mark first, do we have to repeat the question or will people hear it?
Brilliant, brilliant talk. Tons of what you said resonated, resonated with me. You know, I think that the piece that, and I've had this discussion with Jay Devereaux before, the piece that we don't do well is advocate to the public, advocate for the taxpayer, to the voters, you know, this week is an election week. If you heard anything about health facilities, yeah, we know that we're spending close to 50% of our tax dollars on healthcare. And, you know, as you alluded to the Alex study, perhaps 10, 20, 30% of our interventions diagnosed to therapeutic actually in that space. So we're wasting in potentially 200 plus billion a year in useless intervention. But the public,
Yeah,
we don't tell them how. And the minuscule amount that CIHR gets, that scrap over.
You're gonna have to repeat it.
Billion or 2 billion. No, that's not the problem. The problem is that 2 billion should be 10, 20 billion. Or any other R&D batches.
yep.
So you have to repeat the question and it's gonna be difficult.
So, Mark, Roger, I'm sorry if I'm not summarizing it up well, but essentially said that we have an advocacy problem. The public is not sufficiently informed of, this uncertainty and the implications of delivering uncertain medicine and the cost and the outcomes, and we need to advocate better and make it. So I totally am with you on this whole spiel is about transparency, and I think it's transparency beyond the confines of our tightly knit research community, where I would argue that because one thing you said is we don't advocate enough or we don't advocate well, and I would. And here's what I sort of, this is my self critique. I think we lobby quite well. I mean, because you mentioned PJ, we all lobby, but we have to examine how we lobby and why. So we're quite good. There's nothing like a researcher to instrumentalize the public and his or her patients. If you're and I don't want to pick on anyone, but if you're an intensivist like me and you have, a 5-minute sort of window of opportunity because you're taking the elevator with Paul Hébert, you're going to use those 5 minutes to convince Paul Hébert that all of the money needs to go to critical care or that, whatever. So we're quite good at lobbying and advocating, but we are like all those other stakeholders. We have our own vested interests and we're not advocating well. We're not being fully transparent, and there's nothing like a researcher to sort of over-interpret the findings of their own study, right? So I think the type of advocacy that we need to do, but we need to self-examine how we do this. We need to be more honest as researchers about the type of research that we need. It's often not the type of research that we're doing. The trials that I led did not move the dial much, in terms of uncertainty. And I would have loved to do a bigger trial, but I would rather do the small trial that I lead as a PI than collaborate to the other guy's big trial, because that's my currency is whether I publish or not. That's flawed. There's an intrinsic incentive to not tell the full story. So you're right. I don't think we need to advocate more. We need to advocate differently and come to terms with the fact that our own personal academic interests may not be perfectly aligned with the public's interests. So we might need one trial where we currently have 16, right? And that might mean that my next trial doesn't get funded. We need a currency for collaboration on other people's studies. And we need to be able to, as clinicians, this is now a clinician's hat, we need to be able to admit and acknowledge the implications of uncertain medical care. We also don't like to go there. I know PR departments don't like to go there. If you do a study that examines usual care and usual care is inferior, they don't like to hear about it as much as the 2-center, 50-patient RCT of the new exciting device. So that narrative kind of has to change, but it's not about advocating more. I think it's about advocating more honestly and more transparently, and also advocating more.
So I'm just going to take I know, Alan, I'll get to you. I'm going to take a kind of a comment here just because it follows well from Makeda Samrat, who's kind of asking François whether academic competition is a big factor in our ability to do more compared to the UK, since you have the experience.
I mean, it comes to the currency, our currency as investigators, right? Our currency is whether we publish, whether we get grants. And so everything we do is going to be oriented towards getting publications and grants. You don't get brownie points for contribute, not surprisingly, not a lot of sites. You're not paid to participate as a clinician, as a doctor. You make a lot more money seeing patients than you are, than you would overseeing participation in someone else's study. You do all that sort of voluntarily, well, CIHR research or public, investigator-initiated research. You do all that voluntarily, and then no one knows all the work you did because the PI gets to present at whatever AHA or so. There's no system, and you're right. It is extremely competitive, and there is no system to incentivize the type of behavior that you want to incentivize. So, not surprisingly, when there was a lot of, and this, I don't want to irritate anyone in the room, but when there was a lot of consortium money for trials, it funded a lot of the things that you get brownie points for. So it funded new trial units. Like, do we need trial units everywhere, or do you need sites to enroll in the trials conducted by the trial units that exist, right? And there's a difference between a trial unit that is there to promote or facilitate original research, because that's what an institution wants, right? You want the indirects, but the system needs a lot of the community sites to enroll in that. And so you're absolutely, the way the competition has a big role to play, and it fuels the current way of doing business. And we kind of need to think about what we need and how to incentivize what we really need. Now, back to the question was about how it works in the UK. Well, it's the same thing. They're very competitive, but because they are tracking it and because they are monitoring it being the research, they can have the discussion. So they can say, we won't have a gazillion trials for COVID. We'll have one, and then we'll move on to the next question. So by virtue of transparent, sort of monitoring, you're able to say, well, the fastest route to doing your own trial is to facilitate the completion of the other person's trial because you're next in line. But all of that requires that you actually collect the information and share it and distribute it transparently. And then the rules can be sort of,
Okay, so we'll take one more question, Alan Foster, and short question.
Great talk, very thought-provoking. I often, I do a lot of work on quality improvement, public care. And you challenged us a bit during the talk about the Tamiflu example, and you described the different hats you wear. But maybe I'm going to be a bit more provocative. Is what's the point of doing research if we don't listen to the results? And quite frankly, the WHO guideline based on the trial evidence we described is to say that it's actually recommended is perhaps, I think, is an overstretch quite there. So how do we change the paradigm where evidence is generated is used when you take off and put on the path?
It's a loaded question, and this is epistemology, right? It's how we know something, and it's a conditional recommendation. There's no in between. There's no recommendation. So for oseltamivir, it's conditional. It means you can use it, and they think more people would actually want to receive it if they had all the information. But that creates an environment where, as a clinician, if you don't use it, you feel like an outlier, and you're very concerned that someone will say if the patient doesn't do well that so we err on the side of there's a commission bias happening here. So it's not that we don't use the data, it's that we perhaps, I don't think we interpret it as rigorously as we should and not as honestly as we should. If we say something, it's easy to say something is uncertain. It's harder to act on it and say, if it's uncertain, it means that it can be beneficial, it can be harmful, or it can be ineffective. And this high tolerance that we've developed for uncertainty is the problem, is what is problematic. I'm not saying it's bad or good. I'm saying that I find it strange that we are so tolerant of it and that it's not part of the discussion more than it is. I think guidelines are part of the problem as much as anything, because we are making it, when you make something possible, it's very, very difficult to put the toothpaste back in the tube. So it's a complicated question. I'm not sure how to fix it, but
So I'm going to take the prerogative of being the chair here, and I'm going to let my very good friend and one of my favorite internists here ask the last question.
On a different kind of direction, you talked about transparency. I agree with that. How do we overcome Dr. Google or Dr. AI when, like lots of patients, we don't have always the time to talk about, all these conflicts, and then the patients go and get all sort of information that is wrong and listen to wrong.
Totally. So again, it's not going to, it's not,
protect the patients.
So that's not going to disappear. So misinformation was there before. It's probably worse than it is, but that's what critical appraisal is. We're good at that, right? We're able to digest a body of evidence and separating the wheat from the chaff. Like, we're able to do this. That's what, in all of those guidelines that acknowledge uncertainty, they've looked at everything. They said, well, this basically you can throw away. We're keeping this, and even that has its limitations. We've been doing that forever. It's not that we cannot or we don't know how. We need to continue to do more of it and talk about it. I think it's about being more outspoken about the honest truth is trying to extract the signal from the noise. There's all this noise about the molecular weight of IV colloids and the plasma expanding. There's all that surrogate evidence that is really meaningless, because when it comes down to wash, your patient wants to know what it's going to do to them. And when that evidence doesn't exist, we can't erase all of the misinformation that exists, but we can emphasize and underscore the good evidence, and we can say that there's not enough of it, and we can be honest about the uncertainty that sort of affects our everyday business. And when you start doing this, I think you have a different type of buy-in from the public when it comes to research. And
all right, so I think we're going to stop here. I see a lot of thanks in the chat and great presentations and so on. And so again, thank you very much for coming from Sherbrooke and giving this very actually brilliant presentation.